Let's do it.
Okay. Um, Diana, it's so good to connect with you. I have followed your content on Instagram, obviously, for so long, and there's a couple things that I'm hoping we can really focus on.
Yeah, perfect.
One of the comments I hear in the Menopause Chicks community all the time is, it follows the list of suffering and symptoms. And
Hmm.
then someone will say, but my doctor checked my blood work and it's all normal, which is
Yeah.
a word I don't use.
Yes.
I'm wondering today if we can unpack that a little bit
Mm.
and
Yeah,
then
I'd love
maybe
to.
dive into two, maybe, of the top things I would like menopause chicks to be more informed and more confident to have conversations about with their healthcare teams.
100%. I think that's a great start. Yeah, let's
So
do that.
help us unpack blood work and normal.
Yes. So it's such a good point because I would say one of the things that I would love, in a perfect sort of world would be for every single woman when she gets her blood work done to have a follow-up already booked with her provider to go through it in detail and be like, here are your numbers. Even if, let's say, everything looks great, at least she knows what those numbers mean,
Mean.
right? Exactly. And that's, I think, the most important aspect of this is that we don't know, there's reference ranges, but we know some of those reference ranges aren't great, and ferritin, which we'll talk about, iron is one of them, where that range is just very, very large. And we don't know, what normal or what optimal should be. And that's where the conversation between what is normal and what is optimal has really come about. And like I said, it doesn't mean for every single lab thing that you do, the reference range isn't great, but for some of them, they could definitely be improved upon. And I think iron historically has just been one that has been really not taken very seriously, I would say, for a lot of women. And where we know, for example, in perimenopause, when women can have more erratic bleeds, they can have heavier bleeding, we need to be focused on their iron because it drives a lot of their symptoms.
Yeah, for sure. I mean, we have some gaps to fill in for
Mm-hmm.
individuals. I know when I started this work like a dozen years ago, I didn't even understand the connection between bleeding and iron. And then
Yes.
you marry that with a lot of the messaging that we get from media and
Mm-hmm.
marketers that are either take these supplements or you don't need supplements, that's just expensive urine. And, there's this two opposing sides. And I'm like, but wait a second, what about her iron?
Mm-hmm.
And we don't understand that that is one of the most important things that we can be
Mhm.
aware of. So
100%.
iron deficiency will often show up as symptoms.
Mhm.
Speak to us about that.
Definitely. So it can show up as many different symptoms. I think the first thing women think of is fatigue, tiredness, right? Like I feel tired, exhausted all the time. That's definitely one of them. But there's actually many others that a lot of people don't know. So it can show up as difficulty concentrating. Sometimes what people might refer to as that brain fog. Mood changes is a big one. Irritability. It can actually sometimes worsen someone's anxiety, headaches. Heart palpitations is another big one. Restless leg syndrome. So trouble sleeping at night, right? And your legs are moving all the time. Iron deficiency is a huge contributor of that. I think I mentioned dizziness, shortness of breath. There's actually quite a few, and oftentimes. My patients won't have tied that their symptoms were potentially linked to that iron deficiency until they treat it, right? And then they're like, whoa, I had no idea that XYZ, was also linked to it. So again, it shows up in many different ways. It doesn't mean you're going to have all of these symptoms. I'm not
Right.
saying that. It's more just being aware that there is 100% more than just the, I feel tired all the time. And it can really impact day-to-day functioning. This is all about quality of life, of course, right? And how we're showing up. And that's why I'm so passionate about talking about it, because before we maybe move to the fancy hacks and things like that, I think we need to focus on like the basics, right? And I think iron is one of those ones we can do a lot for.
Yeah. And I
Yeah.
think, we probably know a lot of individuals who come to both of us thinking that they are ready to have a conversation about perimenopause, thinking that it's sort of this
Mhm.
foreign bucket that they'd have to lift the lid on and get informed on and not realize that probably iron is going to be step one, or checking their
Hmm.
ferritin. I have an individual story to share with you. So
Yeah.
someone who I love, and at 51, she could not walk up a flight of stairs without being winded, was told to lose weight.
Hmm.
Just this was chronic, repetitive, feeling for her. Oh, probably alongside some of the other symptoms that you mentioned. And
Hmm.
when she finally had her ferritin tested, it was 3.
Oh,
So can you speak a little bit to the numbers and the reference ranges? And I understand it's
yeah.
all very individual, but just to give us some guidelines, so that we don't ignore any results that come back.
100%. So right now, what is recognized under the guidelines is anything under 30 for ferritin is considered deficient, for sure. So that is something we always screen for 100%. Optimal, what I like to see for my patients is anywhere between 60 to 80 is what I'm looking for on blood work. Now, what also a lot of women don't know is that I've seen a lot of cases where they know they have a low ferritin. Let's say, it's been 3 or 12, or it's under 30, it's been low for a long time. They've been supplementing with oral supplementation, tried a few different ones, and it hasn't been going up, in a significant way. A lot of women are not aware that they can also do iron infusion. So you are actually eligible for an iron infusion if your ferritin is under 30 and your hemoglobin is under 130. So
Oh,
if that is the case, you can actually advocate, with your healthcare provider to get that done. And part of the criteria is those two metrics, but also that oral supplementation has not worked for you, right? Because again, it's not going to work for everyone in terms of the absorption of the iron supplement. So that's something to also keep in mind. I'm definitely advocating for that so much more for my patients where, let's say it's been years, they've been trying to get it up, oral is not working. I'm like, you know what? Let's go to an iron IV infusion. Can be very safely done, and your levels can go up very quickly, and women really feel the impact really in a great way.
that
Yeah,
sounds both efficient and effective.
exactly.
Yeah.
Exactly.
One
Yeah.
more thing on iron. I've heard this, so I'm going to ask you the question. Um, Heavy bleeding can lead to being iron deficient.
Mhm.
Can iron deficiency lead to heavy bleeding?
Such a great question. It's actually no, it's actually not a true statement.
Okay.
However, like I would say, one of the biggest things that we're looking at what causes low iron, we have many different things that we need to be looking at, but no, it doesn't directly, like low iron is not necessarily going to directly cause the heavy bleeding either.
Okay.
So I would more look at, yeah, heavy bleeding is leading to that iron loss, leading to the low iron and low ferritin levels. And there's many other things that can do that, like even to find out structural reasons, right? Like so many of my patients had no idea they had fibroids or polyps or things like that that could have been contributing. And then it does change our treatment plan because maybe we need to be addressing that, right? Like we can take all the iron supplements we want, but getting to more of the root of it would be to treat like even maybe those structural things that could be going on. So yeah, that's what I would be looking into.
Amazing.
Yeah.
Okay, so let's go like further down the phase of life to maybe somebody who is post-menopause.
Yep.
And well, I might know a person that this happened to. So, 57, post-menopause for over 5 years, and her cholesterol comes back and it's elevated.
Hmm.
And her physician says, I have no idea why that would be. You've never had elevated cholesterol before.
Hmm.
And you say,
So I see this all the time in my practice as well. And here's what I always like to position this with. Yes, we know aging, can impact our cholesterol levels, but we have to remember that with women, we have sort of the double hit, and the double hit is the menopause time period where we know that the loss of estrogen is going to increase our cholesterol levels, right? So I'm not saying that that's the only thing that's going on, but it is a factor that we have to consider, right? And so I see this all the time that, you never had maybe cholesterol problems before, and now you sort of see it creeping up. Now, here's the best part about this situation is that this is an opportunity for prevention. This is now, there's so many things that we can do to optimize a woman's cholesterol levels to prevent her risk of cardiovascular disease, is that I look at this and say, you know what, that's wonderful. You haven't had it for, elevated cholesterol. It's not like you've had it for decades and decades, and we're really worried about your risks now. Let's take this opportunity now and like, let's talk about what we can do about it, right? It's like that
Like a
position of
tap on the
empowerment.
shoulder.
Yeah, exactly. It's that tap on the shoulder and say, it's okay. Like there's a lot of things we can do. Let's talk about the strategy. And that's, I think, again, that empowering place to be, because it's one thing to say, oh, I have high cholesterol, but then there's no strategy, right? Of
Right.
like what we're going to do about it. And that's the other thing I would say, is that when you come up with that strategy with your healthcare provider, have a plan to say, okay, I'm going to do this, 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 and this, and I'm going to check back in 4 months. Is that okay if we retest my levels in 4 months to make sure we're on the right track? Right? Because I understand there's a lot that comes up then. A lot of women have reservations about medications and cholesterol reducing medications, and that's okay. This is a conversation. We're going to have that conversation. The main thing, though, is that we don't leave that high cholesterol unattended, right?
Right.
For years
Without a
and
plan.
years without a plan. Exactly. So
Don't be
that's what.
planless. Yeah.
Exactly. Just have a plan of action and say, you know what, maybe I don't feel comfortable taking medication right now, but I understand this is something I have to address. I wanted me, have more conversations about this. In the meantime, while we continue this conversation, this is what I'm going to take, these 3 action steps. I always say, just simplify it, right? Like, don't get overwhelmed. It doesn't have to be this entire diet overhaul and lifestyle overhaul. They're just going to stick to 3 things you're going to do until the next time you reassess your cholesterol levels, right? That is that place of empowerment. And so many of my patients are like, great, wonderful, I can do that, right? Like I can do that, no problem.
Yeah.
And that's where I think, to be honest, that in my practice, the thing that is the most empowering is the education,
Yeah.
right? It's the education of what happens, right? If we leave that, where we want that number to be, ideally. And again, it's just that opportunity for prevention and to have a discussion about it, even though, that may have never had to happen before. That's okay. We're going to tackle it. And again, over 80% of cardiovascular disease is preventable. Like that is so empowering. When we think about, if we track it early enough, I always kind of say the 3 things to my patients: the lower the better, the earlier better, the longer the better. Right. So
Mhm.
the lower we can keep it, the better. The earlier we detect it, the better. And the longer we can keep it that way, the better. Right. And so again, having a plan of action is, I think, the thing that I see in my practice that's not typically done.
That sounds amazing. On board for the education piece,
Yeah.
obviously on board for the paradigm shifting, that blood pressure and cholesterol is not a male experience. It's
Yes.
not something that, it's just belongs to your mother and grandmother, that you are being invited to
Yeah.
check those things. And that is one of the celebration parts of menopause too,
Hmm.
right?
Yeah. a
Yeah.
hundred percent.
Okay, but when we were talking about iron, usually shows up symptomatic. What about cholesterol and high blood pressure?
Great
Is it
question.
silent or are there symptoms?
Yeah, so typically for the cholesterol component, it's silent. Yeah, we know cardiovascular disease, it's called that silent killer, in the sense that you typically don't have symptoms until an event has occurred. Now, with blood pressure can be a bit different because, some people can have dizziness, headaches, and then that's kind of the invitation. I actually often even see like the ringing in your ears, so to speak. Some of my patients have that, and then that invites them to, high blood pressure, you definitely can have symptoms that will warrant that checkup. But again, like a lipid panel, cholesterol panel, for a lot of people, you're doing this on your regular testing with your healthcare provider. And so the good news is that we don't necessarily need so much, again, fancy testing. We can just monitor your like standard, blood work that you do with your family doctor. The key is not only running it, but having a copy yourself and then going through and knowing what those numbers mean, right? Like that's the added component to it. But 100%, a lot of people will not experience the symptoms with cholesterol. And what happens is they reduce their cholesterol, but they feel the same. So I feel like the motivation is sometimes not the same, because think about, if you have a migraine, you take something and the migraine goes away. That's like a motivating factor, right? Because you had pain and then you went to no pain. Now with cholesterol, you had high cholesterol, you reduce your cholesterol, but you can feel the same, right? So sometimes that's what we have to keep in mind is that you're not going to feel that plaque development necessarily happening, but it's your blood work, right? And a lot of our screening tools tell us a lot. And that's what we want to go off of is those metabolic markers on blood work.
I think that's a really good reminder to keep this conversation open and keep it
Mhm.
going because for anyone listening to us today, it's like if they have a plan in action with their healthcare team, it's just a reminder, keep going, keep reviewing.
Exactly.
Yeah.
Exactly.
Can you speak to, I always like to talk about, what's on the menu and what is on the menu for addressing cholesterol.
Yes, so I typically recommend your like lipid panel, like your standard lipid panel, which you, like I said, can get with your family doctor. I also recommend testing ApoB. ApoB is another marker that you can do on blood work. Your doctor can run this. It is a more precise marker of basically atherosclerosis of that sort of number of particles that we have floating in our bloodstream that can contribute to that plaque development. And then the other marker I always recommend is lipoprotein A. Lipoprotein A is another type of cholesterol that is over 90% genetically determined. You actually only have to run this marker once in your lifetime over the age of 40. So that's what our Canadian guidelines recommend, the Canadian Cardiovascular Society. And so if you've never ever had that checked before, I would really recommend talking to your doctor. Again, covered by your provincial plan. It's just about asking sometimes for it if it's not, it hasn't been tested before. So you don't have to do regular screening for the lipoprotein A, but you do want to do it at least once over the age of
Just
40.
know. Oh, wow.
No,
That's
yeah,
fascinating.
yeah.
And then what's potentially on the treatment menu?
So I always say whether medication or not is on that treatment menu, we know, of course, that having a really good, healthy diet and exercise is always going to be part of the plan. Good sleep, right? So whether you're on medication or not, we're always going to be recommending those things. So from a diet perspective, we really focus on your fiber component, right? So increasing your fiber, making sure you're getting 30 grams a day of fiber and at least 10 grams of that being soluble fiber. So we really focus on that. Decreasing saturated fat, we know can make a huge difference as well. Look at alcohol intake, that sort of thing. Again, exercise, I think goes without saying. There's so many health benefits, of course, of
Yeah.
exercise. I always say we can't replicate exercise in like a pill or a supplement because just it's very hard to bottle that up, but it's fantastic for health. And again, we always just start where you are, right? Like if we just start maybe with 15 minutes a day of walking, amazing, right? Like we can always get started wherever you are at. And that's again the empowering place we want to be. The conversation of medication I really have a lot of with my patients as well because there's so many myths around cholesterol reducing medications and statins. There's a lot of fear around it. I get it. We maybe have had family members who had the muscle associated side effects. They had maybe symptoms with
Mhm.
it, you know, and maybe we know people in our lives and combined with the misinformation about things like it will contribute to diabetes, will cause dementia and things like that. Like again, we have to be very careful where we're getting our information from because a lot of these things are not true. The one thing I will say is, you know, let's say we're doing the diet lifestyle, we're doing a lot of integrative approaches, and we're not seeing that switch that we want to. That's where, again, the conversation changes, right? About, okay, maybe this is something that we do consider. It's very safe, very effective, can reduce your cholesterol levels by over 50% in a pretty short time period. Let's consider it. I think it's actually a very important part of our toolkit. I really do. And I think it is underutilized when we talk about cardiovascular disease being the leading cause of death in women, right? Like this is important that we're having really informed consent conversations. And that, again, education piece is what will lead my patients to considering it. It's a very different conversation, as you can imagine, than here you go, take this pill, right? Like we need to feel comfortable about it. And I completely understand that. And that's where these conversations are so important. So if I would suggest anything to anyone listening to this is that make those list of questions, right? What are you what have you read online? Like have that conversation with your healthcare provider to be like, hey, I saw this, you know, and I read about this. Like, what are your thoughts on that? Can this really contribute to my risk? You know, what are the pros and cons of me doing this? For majority of people, the benefits of being on that medication can outweigh the risks 100%. And again, it's about coming back to the fact that what we care about is your outcomes, right? We know that if we have cholesterol within range, we're going to significantly reduce your risk of cardiovascular disease. How we get there might look different for everyone.
For sure. You just said something that's music to my ears, and that is inviting patients to show up and say, I heard
Mhm.
this, I read this. Can you please interpret it for
Yes.
me?
Yeah.
It's so important. And you also mentioned, there might be hesitation around medication.
Mhm.
But I think we all, maybe we know somebody who suffered side effects, but we
Yeah.
probably all know a lot of people whose lives were
Yeah.
saved as a result
Exactly.
of it too. Can I just ask you this question about medication specifically for preventing cardiovascular
Mhm.
events? Statins forever, or can I take something temporarily with the hope that I might not need them forever?
Great question. It depends if we're talking about primary or secondary prevention. So,
Okay.
with secondary, meaning let's say you've already had an event, you've already had a stroke, heart attack, yes, it is for life, to prevent obviously the recurrence of
Got it.
another one. So, I just want to highlight that.
Yeah.
If we're talking about primary prevention, so you've never had, any event happen and you are looking at going on it to reduce your cholesterol levels, that conversation about long term is so, again, dependent on your risk factors. So I'll give you an example. Let's say I had someone come in, they also have really high lipoprotein A, that genetic marker that can put you at really increased risk. The way that I explain this to my patients is that when we have, let's say, these cholesterol, these balls, in our bloodstream, these risk factors that we have, like high blood pressure, high lipoprotein A, they make these balls more sticky to the artery walls.
Mm.
And so, if we have more risk factors that will increase the risk of these balls sticking to that artery wall and depositing that plaque, then it might, like I said, change our conversation because that lipoprotein is always going to stay elevated. Right. Right now, currently in 2025, we don't have medications to lower that lipoprotein. It's currently being studied in clinical trials. So we will have something in the future. But right now, we don't have anything to decrease that lipoprotein. So I want your cholesterol levels probably even lower, right, than someone who doesn't have that high lipoprotein because you have additional risk factors, right? I want to reduce as much as I can the sticky things that are going to make those cholesterol balls stick to the wall. And so in that person, I might want them, on that statin medication longer term because they have additional risk factors, right? This is a continued conversation, with your healthcare provider. And so with primary prevention, I always say, we're going to go on it. You're going to see that benefit. But then we can revisit the conversation, right? We can see where it goes. And that, I think, again, invites that opportunity to continuously talk about our cardiovascular health with our providers versus, going on medication and then not continuing that conversation, right? We want that to be like an annual basis where we're having that conversation about, okay, do we go from here? So it's a little bit hard to answer. It depends on these other
Yeah,
risk
for
factors.
sure.
And for some, like I said, it might be longer term, but again, the lower the better, the longer the better, right? If we can keep these levels for low enough, then we're really, really preventing any chance of that atherosclerosis or that plaque developing from occurring. Yeah.
I love this. We've been chatting for 20 minutes. You are a Menopause Society certified practitioner. You have, I think, your patients have the luxury of having even a longer conversation for their appointments where you can really get to the root cause. You
Mhm.
can really sort of have that continuum of care. And, you know, under the menopause umbrella, I think what we're doing today is cracking open those things that aren't always discussed or even thought of or
Mhm.
associated with the word menopause. So I just wanted to take a moment and tell you that I have learned so much from you.
Thank
And
you.
thank you for the amazing work that you do. Tell everyone how they can get a hold of you.
Thank you, Shirley. So I'm really active on Instagram at Dr. Daiana Castleman. You can find me there. I do not have TikTok. Do not plan on getting TikTok. But I would say Instagram is my most active place. And then website, of course, DianaCastleman.com. Yeah. And
Amazing.
thank you for all the amazing work you do, Shirley. You really advocate for all of us, and we really appreciate you.
Thank you so much. Thanks for doing this today.
Of course. Thank you.